Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Jack.
John.
Today, we thought we would talk about the difference between the management of lower limb versus upper limb and tendon pain.
And more importantly, is there a difference?
Well, I think the thing that's important to kind of identify is that clearly in the research, there seems to be a big differentiation in which those upper and lower limb tendon issues are being managed.
Yeah, and we talked about this recently, and this is in reference to a commentary done by Sean McAuliffe was the main author. I know Peter Malliaris was another key author, of actually just looking at the literature in upper limb versus lower limb tendinopathy and the population characteristics specifically, because it's interesting to note that there's some key differences between the two.
Well, yeah, I think that paper really elucidated some big differences that maybe suggest why the management, at least in the literature, seems to be so different with recommendations.
And the presentation itself. Yeah. So
do you want to outline it for us?
Yeah, well, to give it some context, if you actually look at something like Achilles tendinopathy, the prevalence in athletes is far greater than in non-athletic populations. And that makes a lot of sense because it's very unlikely that you're going to give yourself a Achilles tendinopathy if you're not performing a high amount of physical activity. And this is pretty evident.
You do sometimes get them with the sort of, metabolic syndrome type patients, particularly like older females. I've had a few that have developed it from like a one-off walking episode, like a hiking or something like that.
Definitely. And I think what's more important to highlight here is when you look at the literature looking at, say, Achilles tendinopathy management or presentation, it's typically done in athletic populations because it's much more prevalent. And as opposed to, say, something like lateral elbow pain and developing tendinopathy in the upper limb, where we see a lot of the literature done predominantly in your general population. And so thinking about population characteristics, these are people who are typically older, people who typically have low levels of physical activity, who may have other comorbidities too, things like being overweight or obese or other common chronic diseases when you think about the metabolic syndrome, type 2 diabetes, cardiovascular disease and so on. And this has led to differences in presentation because if you think about something like Achilles tendon pain, particularly in an athletic population, it's usually very localized.
Yeah.
In fact, most of the time it will always be. In contrast...
Well, that's almost one of the characteristics that people use for differentiating whether it is Achilles tendon pain. Is it very localized?
Not in isolation, but it's certainly one thing that's useful to consider. And this is in contrast to someone, particularly say from a general population group who presents with, say, lateral elbow pain. It typically will be more diffuse in nature. They actually might experience brachialgia, like pain through their upper arm. They may experience some neck pain as well. And if you think about some of the key factors associated with lower limb tendinopathy in an athletic population, often you're going to see a particular change in their load or in their intensity, or perhaps there's other factors that lead to a dysregulation of their collagen turnover and metabolism, as opposed to the general population group where there might be much more of an insidious onset. And so it brings the question of, well, why are we seeing these differences in the presentation, and why are we seeing differences too when you think about the localization or the more diffuse nature of upper limb tendinopathy versus lower limb tendinopathy? But the first thing we need to consider is the actual characteristics of the population group. Because when you think about the general population who present with those more diffuse, non-specific pain presentations with regards to, say, rotator cuff tendinopathy or lateral elbow pain, they have certain characteristics that predispose them to developing central sensitization.
What are they?
The big ones are poor metabolic health, which you alluded to before, and this is why you also see, say, a higher prevalence of, say, gluteal tendinopathy also too in middle-aged to older females. There's multiple factors associated with that, but one of them, and for developing any type of tendon pain, is having metabolic dysfunction. So we can think of that as a manifestation of, say, type 2 diabetes, but a lot of people are pre-diabetic where they may have blood glucose dysregulation, they may have changes in their triglyceride levels, high triglycerides, low HDL being a big one. they typically have much higher levels of fatigue. They typically have much higher levels of fat mass, which also changes the inflammatory environment. These are factors we know that influence the development of central sensitization and therefore the potential to develop pain more diffusely.
So why do they influence it?
Because of how you think about, like from a neuroscience perspective, of about sensitization of the peripheral tissue environment because of changes in, say, inflammatory markers, but also even within the central environment because of changes in neurotransmitters and hormones that also influence how that signal is interpreted too. So, we need to be thinking with that general population group. We can't look at it purely through the lens of a musculoskeletal problem. It's kind of similar to, say, something like osteoarthritis.
And do you think that, because when you presented this paper to our group, I sort of was thinking about it a fair bit. And I think it's one of the key reasons why, whether we want to or not, we tend to treat them very differently. As a clinician, if you get someone who presents to you and one is older, more sedentary, clearly has, other comorbidities, maybe they're a bit overweight, the way that you attack what you do with them and the intensity and the magnitude of the kind of intervention you put in place is very different to someone who comes along and is very athletic, has developed, as you said, like Achilles tendinopathy from their running volume, for instance.
Well, the other thing I think of too is expectations, because if you get an athlete coming in with Achilles tendon pain, they can still do a lot. And they're willing to tolerate a certain amount of discomfort. General population, that's a much harder sell. It's a much harder sell to say to someone like, look, there's likely some changes at the tendon level. This actually may take some time to actually get a resolution of symptoms. And more importantly, we need to address not just musculoskeletal factors here, but other lifestyle factors that influence the overall state of your health and therefore the likelihood of you experiencing pain and developing more diffuse symptoms.
Do you think that's why when you talk to people about, I think I've seen a few times people ask, say, the tendon injury sort of management and research group in Australia, the difference between lower and upper limb. And they often say, like, upper limb, we're not sure. We don't know what's going on with that. Do you think that potentially what's happening there is, as you mentioned, you need to unwind a lot of other factors before you're actually going to be able to make significant change to the tissue itself? Yeah,
I think actually it's getting better in terms of identifying what are the main modulators here. Because, again, I look at it similar to something like osteoarthritis, which people will typically associate as a musculoskeletal problem because you have degeneration of the joint itself.
I was actually explaining this to a patient this week, how the general observation with osteoarthritis is that it's a wear and tear problem. That you've done too much activity and your joint has degraded. But actually, there's a lot of evidence to suggest that's not probably the main thing that's driving a lot of that. Now, it's not that there aren't people who end up with particularly like chondral degradation because they've done a lot of sport. But I was explaining, like, a relative of mine who's not super healthy, has been sedentary their whole life, has arthritis in every one of their joints basically. And they're like, I've just done too much. And I always think, like, you've done too little, not too much.
Well, and look, I think we look at say, someone with osteoarthritis who experienced a traumatic knee injury in their 20s playing footy, but otherwise is actually quite healthy and has good indications of health and well-being, the management of that will be somewhat different to someone who is typically sedentary, has poor health markers and develops OA as a secondary problem. And I look at something like tendinopathy, and this can be applied to the upper limb or the lower limb, where are we dealing with a young, healthy, athletic population where they've had an alteration to their collagen metabolism and potential development of pathology because of a poor management or an issue with their training load or volume, but otherwise has good markers of health, versus are we dealing with someone who has indications of poor health? Maybe there's been a change in their training load because they've started doing physical activity, but maybe not. Maybe it's just an insidious onset. Those are two very different presentations that require more of a focus on some of the physical parameters and then others on some of the non-physical parameters. And so I think this is where it can be challenging, and I know, clinically, I'm sure a lot of people who have worked with these types of
Well,
presentations.
I think we all find these challenging. You know, I still find these extremely challenging to be able to manage some of these upper limb, tendon pains developments, because they're often very obstinate in terms of the progressions that you can make with them.
Absolutely.
The timelines always seem much longer.
Yeah.
And you need to be very, very consistent with them. Otherwise, you end up in a position where they will be very resistant to changing.
Yes, and like even just thinking about basic adaptation of connective tissue in terms of the type of load and also like the magnitudes of load that are required to actually see change. And again, coming back to the expectations of what's the willingness of the individual to be able to tolerate some level of discomfort, which is pretty common with tendinopathy, but still be able to apply high amounts of mechanical load to create changes. In addition, and this is probably often the harder thing, of how do you change those other factors in their life that have such an influence on the pathology in their presentation.
I think that's, discussion. It's about the education of okay, typically with these, you've got these factors, we need to address some of them as we go.
Well, obviously, I mean, this is where I think it's important to, one, have knowledge of this, but two, do you actually have people that you work with that you feel confident in their ability to actually address these effectively too?
What's the thing? That's why it's really important, to have GP, to have dietetics, to have these other people involved in the management for these people.
Yeah, but then I think also focusing on the things that we can more directly address of, again, going back to just fundamentals of adaptation of what are the type of mechanical loads you need to apply to create positive changes and adaptations to the local tissue environment, but even then too of actually trying to improve their overall systemic well-being by actually creating changes in their inflammatory state through physical activity as well. Because I actually also think, and again, thinking about the more general population who have poor health markers, probably finding that balance of applying more localized load to create very specific tissue changes, but then also thinking about, can we actually apply more general physical activity to create systemic changes as well? Because we can certainly use general exercise to create some positive change that influences the overall state of that person, and therefore also where they're experiencing pain, wherever that may be.
All right, based on that, how can we start to navigate how we're going to manage someone who comes in with a lower limb tendinopathy versus an upper limb, and what are some of the things that, even if we use some examples, what are some of the things that we're going to do?
Well, look, again, this is where it comes back to the first point you made and our question of, do we actually need to look at them differently, really? Is there anything that is going to be specifically different with the overall metabolism and adaptation of tendon tissue within our upper limb versus our lower limb? Now, look, there may be some differences in the biomechanical. We can think about there are some biomechanical differences in how the upper limb versus the lower limb is used. And we can actually think about how that influences rehab, perhaps getting towards the end stages. But ultimately, tendons still respond similarly, whether it's upper limb or lower limb, in terms of the amount of strain that's required to induce adaptation at a local tissue level.
Do you think that, because of the difference in the forces that are experienced in the upper and lower limb, that tends to be one of the main reasons why we get the loading parameters wrong, or we're not sure of where to go with it?
Well, I look at it as being relative, though, because ultimately you want a relative load that's pretty heavy, basically, in terms of actually creating changes to the tendon tissue. I do see that as a problem, though, in terms of the typical protocol for treating, say, a rotator cuff tendinopathy with using, say, a TheraBand as resistance, which may be an appropriate starting point if they have really low capacity, but where you actually progress on from that point.
I think one of the things that, and we've spoken about this before, and sometimes we've been critical, but the thing that's useful for it is the fact that it is a high magnitude load, is the use of isometrics, for instance.
Yeah, absolutely.
And I think the key recommendation that people tend to give, even if it's not something that you use for the whole management, is that isometric force needs to be at the closer end to their failure point.
Absolutely.
The amount of mechanical stress that's going through their tendon is going to be applied at a level that is high in the lower limb.
Yes.
Versus in the upper limb. As I said, if you start with something like a TheraBand and it's relatively easy and it's nowhere near the maximal voluntary contraction, the maximum level that they can create, it's not anywhere near the same magnitude that we're applying for the lower limb.
Yeah, and I think that's where you need to think about, well, one, don't think of isometrics itself as being like a magic bullet, because there's nothing different in terms of at a tissue level in terms of the actual mechanical tension that's created.
No, the big difference is it's a high amount of time under tension with a high magnitude of force application.
And you're constraining the parameters of what particular range you apply the load, which, when it's potentially very irritable, may be an appropriate starting point.
So on that then, do you think that in the right context that, say, isometric loading for the shoulder or the elbow, for instance, is appropriate then?
Oh, potentially. I mean, there seems to be a bit of mixed data with regard, well, when we say better for the shoulder, we're really, the idea or the relationship with using isometrics, people typically associate with pain reduction. Now, the literature on isometrics for pain reduction is a little bit mixed. There's some evidence saying that it's effective. There's some evidence that's saying that it isn't. So, again, I just think that's really about setting up a really simple, safe-to-fail experiment of if they are highly irritable, sure,
let's
you can
do
start
this for a period of time and see what the response is. Yeah.
And then then we can start to ask if it's not actually having a pain reduction, well, what's the reason for that? Are we not reaching the appropriate magnitudes of force to doing that, or are there some other non-physical factors with regards to nutritional status or intake or some other comorbidities that are also creating a much more sensitized state, both peripherally and centrally? But, at the same time too, I think it's also important to think about where is their appropriate starting point in terms of the loads they can tolerate, and again, taking into consideration of what is expected in terms of symptom development and creating appropriate parameters, but then where do you actually go from there? And again, I tend to try and keep things simple and apply universal principles to the body of, if someone comes in with an Achilles tendon pain and they're a sprinter, where do you want them to get to and where are they currently? And what are the steps that you need to put in between to make sure you actually get them there? And also build the capacity of the tendon to be able to do what it needs to do, and that is be able to store elastic energy and then be able to release it. And again, I think the upper limb is similar. Now, again, it depends on the sport that you do, but typically if people are physically active, they're going to be utilising and creating arm movements at different speeds. So we need to be thinking about how we actually integrate higher forces through ranges, but then potentially also higher velocity movements as well.
I think that's the key one, isn't it? Because I feel like that's the missing link for a lot of the discussion that happens in the rehab for, say, shoulder, or even for the tendons in the forearm and elbow, because it's not that they're not discussed. There are, I'm sure, lots of practitioners that think about this stuff often, but I think in the general literature associated with management of these kind of injuries, it's often about, okay, get the high magnitude load in, maybe it's over a prolonged period of time under tension or it's isometric, but there isn't a lot of discussion of velocity. And when you think about what the upper limb does, particularly for athletic motions, if it's throwing, if it's striking an implement, if it's, serving in tennis, stuff like that, it's happening even at extremely high velocities.
Yeah, and this is when we're getting into more athletic populations. But the way I look at it too is you need to create a certain amount of strain of the tendon. Now, if you apply high forces over time, you're going to create strain which makes it stiffer, which means that over time it's actually going to strain less and less because it becomes better at maintaining stiffness with that high force load. So how do you then start to create more strain? It's got to do with the rate of loading, where you start to get that more stretch shortening.
Do you want to explain that a little bit? Because I feel like people don't really understand what happens within that development as you apply different types of loads to the tendon and how they adapt over time.
Yeah. Well, I think we've talked about this a few times, but it's an important thing to remember that our ability to generate high amounts of force has to do with how we are able to store potential energy. And we do that in the lower limb with making ground contact. So, this is something that we've talked about with regards to running mechanics of, if you look at really good sprinters, one of the key characteristics they have is the ability to actually attack the ground and apply force down. Because you think about it, the more you accelerate your foot down to the ground, the larger the ground reaction force. Now that force has got to go somewhere, And if you have really good coordination strategies, it's going to be stored through your soft tissue system, specifically tendons. That's what they're actually designed to do, to either transmit force or to be able to store and release force. And we can think about that similarly with regards to the upper limb. Now, there's a little bit of a difference in the sense that there's not a ground reaction force, but we typically will generate and transmit forces from the lower limb up into the upper limb. So think about like a tennis serve, or think about something like, like a javelin throw, where a lot of that is about creating momentum through either running, say javelin, or through winding up the whole system in, say, tennis to do a serve, to be able to generate forces from other areas of the body and then transmit that. But if you're thinking of that being created purely from the muscle, you're going to find that there's a lot of limitations to how much force you can create. And you can just think about that in terms of what's your 1 RM for a squat, or what's your 1 RM for a bench press, for instance. But you can start to see that we can generate a lot more force if we can effectively create forces from other areas of our body and make sure we can transfer them effectively through our body. And I think that's also something to consider too when you think about upper limb tendinopathy, is how effectively you can transfer those forces from other parts as well.
Do you think that that's something that's often, it's probably something that I haven't necessarily considered enough, is like how much transfer are you getting from the movements through the trunk, through the lower limb, to support what's happening at, say, the shoulder or the elbow?
Yeah, absolutely. And I think of think of something like a tennis serve, of like how effectively can you create movement through the kinetic chain from the knee, hip, spine, all the way up into the chest, so you can actually get that transfer of forces from the lower limb to the upper limb. Because I think of people who are stiff or rigid in one particular area, that creates like leaking of energy, so to speak. So again, if you're a good athlete and you can perform well, you'll find strategies to be able to accommodate that deficiency within that kinetic chain. But it might come at the expense of overloading other tissue elsewhere in the body.
And you'll end up developing some sort of overuse.
Yeah, absolutely. And this is where we're thinking about with, say, optimizing or helping to effectively adapt tendon, how we actually make sure we progress that person through higher forces and then higher velocity. And then I think also with that, so that brings up two things. Are we actually applying high velocity movements through the upper limb? Because like we do that a lot in lower limb tendinopathy. You're going to get something to do, plyometrics, running activity, maybe different types of power activities. If you think about using, say, weightlifting derivatives, are you applying those same principles to the upper limb? And this seems to be something that seems to be not really discussed in the literature from what I can see anyway.
Yeah, well, I think that sort of opens up the door for us to explore, some of the different things that we would do across that spectrum. We want to pick like elbow or shoulder? Do you want to? It's probably easier for people to maybe visualize some of the shoulder stuff, but that you would work through. And I think it's probably important if we do it across even like a sedentary population versus an athletic one, to see like how you would kind of progress through some of that.
Yeah, and look, I think the same principles apply. I think the difference between your athletic population versus your sedentary population is their starting point, but also their adaptability. Because the older you get, typically the less your adaptability becomes. And also for your general population, if they have comorbidities, their inflammatory response to mechanical stress may be high and may take them longer to recover before you can do a repeated bout.
Yep.
But so yeah, let's think about it. So one, what are the parameters or expectations you set for developing upper limb strength in terms of force production? And are you doing that with, and two things I think about is, are you doing that through different planes of movement? And are you doing that through different directions as well, which sort of fits in with planes of movement? So I'm talking about pushing movements versus pulling movements, upper limb movements versus, overhead movements versus at shoulder height or below limb. And this is where, again, it comes back to thinking about, well, how do you test the athlete or the individual? Where do you identify deficits within their particular range? Is that overhead? Is that at shoulder height? Is that below shoulder height? So we need to start expanding out of thinking of, well, how do I not just apply potential mechanical load through, let's say, rotator cuff in this example, because that's the example, that's what tendon is going to become problematic in the shoulder, but thinking about how you apply loads through different planes and positions.
This is where, as soon as you start saying that, I'm sure you have clinicians screaming right now, well, it depends on the sort of orientation of the acromion and how much, compression is going on.
Well, I think the other thing too is like, don't we get maximal activation at this particular position for the rotator cuff? And I think what you need to remember there is activation is a pretty EMG activity is a pretty poor proxy for determining the amount of mechanical tension the tissue experiences. So certainly neural drive, which EMG is a proxy for, now people would argue that depending on whether it's isometric or isotonic and so on, but it's not the only thing, because the reality is the amount of actual load you're applying through the upper limb is going to be a big factor for the amount of mechanical force. It kind of makes sense, in addition to things like the rate of force development. And the other big one is also fatigue. And actually we also could take into consideration the magnitude of the metabolic stress for tendons, because it seems to be very responsive to that.
Because it makes me think straight away, like one of the biggest things that typically I think is difficult with managing something like the shoulder is often it's so heavily influenced by the soft tissue and connective tissue structure and the postural structure, the postural behaviour of the spine
and the whole upper limb girdle sitting on the spine,
And I think one of the big factors that you have is one of the reasons why you do end up continue having tendon irritation occur in the shoulder, even if you're getting the loading parameters right, irrespective of, say, some of these metabolic things, is because
biomechanical
insufficiency and in poor positions, you're probably getting some compression that is going on in that subacromial space.
And look, I mean, what does that highlight then too is thinking about what is their range of movement, what's their actual movement capacity like, and again, not just through the shoulder here, we're talking through the kinetic chain.
That's an interesting question, because obviously people know your background is in flexibility and exposure to yoga and things like that. So I always think one of the things that I learnt the most when I was exposed to some of the stuff with you was what's actually considered a reasonable amount of upper limb and particularly spinal range of motion compared to what most people have.
Actually, just on that note, because it's such a common problem where people have such poor myofascial compliance around their scapula, which therefore affects their shoulder movement. And I think that's often a big issue when you look at upper limb range of movement. It's not the only area of the body it applies anywhere, but is you might look at shoulder range of movement in isolation, you might look at thoracic range of movement in isolation, you go, it's actually not that bad. But when you actually start to create a bit of tension through the soft tissue system, you start to see massive deficits. So like a really basic example, think about doing, say, thoracic rotation and sitting, typical range of movement assessment, as opposed to doing thoracic rotation where you do the typical seated twisting position where you have your shoulder over your leg. It creates a lot more tension through that particular chain from the glute max, thoracolumbar fascia, contralateral latissimus dorsi. And it always amazes me when you're like, how much it changes. And what that's reflective of is their articular movement in isolation is okay, but when you start to create more mechanical tension, which is reflective of what we do in movement, we see a massive deficit. And it's funny because it's actually one thing I've always wondered, where I remember reading this book by an orthopedic surgeon.
I knew this was going to come up. I was waiting for this.
Well, I can't remember the name of the book or the author.
Hanging around.
But interestingly, he puts forth an issue that we have now is like pre-evolution to humans, we were hanging out in trees all the time.
Yeah, we were apes who would hang from trees.
Yeah, which I think it's called brachiation, where you're literally hanging from a tree, from something. And think about the stretching that creates through the musculature of the upper limb. You're actually stretching through a lot of those large muscle groups that cross from the trunk to the shoulder, particularly things like the pecs. It is
interesting because it's definitely an assessment that I use, is seeing whether someone can actually just do a dead hang from a bar. Yep. They don't even need to try and pull up or anything. Actually just like, are you comfortable hanging here? And some people really struggle because they're like, I don't feel like my shoulder has the range to get into this position.
Yeah. I think the other interesting one too is when people actually may have limitations in their movement that may or may not be associated with pain, getting them to do a hanging movement and reassessing and seeing quite a big difference in not just their range of movement or potential symptom, but even like overhead force producing capacity. because all of a sudden you're able to get into positions in a much more optimal biomechanical position in terms of relative movement of the scap versus the shoulder. You keep better length tension relationship of the associated musculature, and you can actually produce force at a greater level.
So going back to my question, what things do you think people should be able to do from a basic range of motion point of view for their upper limb, thoracic spine, scapula and shoulder girdle?
Yeah, okay, that's a good question. Well, I think a common measure I will use is looking at doing something like a back bend.
I know, yeah. Well, that's to me the things that I always look at, and so people have a bit of an idea, is if someone can't hang from a bar comfortably for 30 seconds, right? Sometimes it might be a grip strength issue, that's fine. But if they actually can't be in that position, even say with supported feet, then, and they're saying it's due to lack of movement or pain, that's an issue. They can't do a handstand position, even if it's from like a pike position with their feet elevated on something.
The other one I often look at too is a downward dog position, and looking at the relative movement of opening up through that thoracic shoulder region to other parts of the body.
And then the last one, as you said, is like a back bend or an arch or a wheel, sometimes it's called. And it's really interesting because typically females usually have done this more. Like you say, do you remember back when you were a kid and you do this movement going up into, a wheel or an arch position? Like, yeah. So have a go. Like, I can't do that anymore.
Yeah. And look,
a lot of males are much worse. They tend to be much stiffer through a lot of those chains.
Yeah.
Not always, but they tend to be.
True. And look, the way I look at it too is the shoulder joint, as in the glenohumeral joint, is inherently unstable. Now, that's not an issue in isolation. It is, though, when you have deficits through the kinetic chain, because the shoulder is actually very good at moving a lot more to compensate for that deficiency. But then, again, thinking about tying this in with, say, tendinopathy in the upper limb of the shoulder, how does that change the requirement of the rotator cuff musculature to help try and actually support and stabilise that joint if you're got so much deficits through your range of movement and movement capacity overall?
Well, that's the thing. I think it ends up actually changing the function the rotator cuff is there for. We know it's there for stabilization, but it ends up having to do a very different role if you have such little movement elsewhere. Potentially they become more prime movers than they would like to be.
Absolutely. I always follow the principle of the body follows the pathway of least resistance. So, and again, just tying this back into thinking about upper limb tendon management, you can be doing all the appropriate loading locally, but if you haven't identified some of the other key modulators within the kinetic chain, you're probably going to run into similar issues time and again because you're altering the biomechanical load through that joint and what it's actually effectively or designed to do in an optimal sense, and creating a lot more movement and therefore tension through the tendon tissue that leads to potential pain and injury. And look, I think the thing too is you might have people going like, well, I've got a 60-year-old coming in with shoulder pain. I'm not going to get them to do a back bend. Like, sure. Again, think about this in the context of the population group you work with. But this is something that I think is useful to consider as you move through and progress your rehab and have the opportunity to assess this. It gives you really good information about what is their movement ability like.
Well, I think that comes down to what we mentioned earlier, like when the person walks in, your expectation changes based on their appearance, and it probably shouldn't. And that's the bigger issue. If someone comes in and you assess their, say, spinal motion, you assess their scap, and you go, look, they're 70, they're very stiff, I don't think that's going to change. You're actually probably putting them in a position where a lot of the loading that you're deciding to do is actually going to be heavily compromised by the fact that you actually are not addressing what is maybe one of the key drivers, which is their lack of range of motion around the shoulder girdle itself.
Yeah, absolutely. Yeah,
so, we often get caught in that because we think, I can't change that. But you probably need to think about trying to address those things, even if it's starting at a much lower level of, intervention.
Yeah, absolutely. Yeah, I mean, that just comes back to the basic things we talked about in terms of timelines and expectations with that regard, specifically. But I think, we brought up before then thinking about moving through that force velocity spectrum. I think the other thing we need to think about then is once we've developed that good foundation of movement capacity, once you've developed some of the force producing capacities you want through different ranges, through different planes, is then how we progress that into doing some high velocity movements. And this is obviously going to become much more important when we think about athletic population groups who are going to do a lot more fast upper limb movements. And that becomes obvious in sports like tennis or throwing activities, but I even think about activities like team sports like AFL, where you're doing a lot of kind of fast overhead movements as well. So how do you actually make sure that you are developing those strategies to be able to support the upper limb through fast movements?
Well, even, it's, as you said, that velocity is always relative as well. Like I think one of the key, and I'm sure many people have kind of heard this before, but as a clinician, one of the things that people often mention when they say, oh, my shoulder still hurts, it's usually when they do something they say it's like a little bit, unexpected. They kind of like reach for something and they go, oh, my shoulder still really hurts. Yeah. And to me, that's an understanding of the fact that velocity for them is at their higher end, even if it's not, it's not an athletic movement, but they're reaching out for something, and that's actually going to be done faster than a lot of the exercises that you prescribe. So it creates this issue where there's still a gap between the velocity that they're experiencing and what you're putting in as an intervention. And that's where you actually need to expose them to things that are a lot quicker than what they're even going to be doing, so that when they are, unexpectedly undertaking that task, they're potentially nowhere near that limit.
So I was going to say, where do you start then with moving into that velocity spectrum?
Well, I think it comes down to two major factors for me. One is making sure that I feel like they do have the force application. And the big one is actually that you've done some of that force application in the planes that are often the difficult planes of motion that people struggle with. Like, I wanted to bring this up because I think it's a really valuable thing, is we do a lot of stuff from the behind head position, right? So overhead, we do a lot of things and we also do a lot of, if you say like a barbell, even if it's, or a stick even, we do a lot of pressing behind your neck, behind neck press or behind head press, because that plane of motion is really, really valuable for making sure that they can actually maintain the flexibility and the movement through their shoulder girdle and actually use, as you said, some of those connected chains in a useful way that actually is creating some force. That to me is really, really big, and I think it's something that gets neglected. And even in the gym world, really interestingly, like behind neck pressing is really out of favor, which I don't really understand why. I don't know the history of that. You see a lot of texts, like people like, don't do behind neck press, it's dangerous.
Because they're too stiff.
Well, I don't know if it's too stiff or they think that there's the risk of things like dislocation.
Well, and look, I mean, this comes back to the thing of if someone does have that prevalence, it's like, well, how do you make sure that you apply interventions to mitigate that as much as possible?
Well, interestingly, not that this is on this topic, but with people who end up with dislocations, one of the big reasons I think they maintain their risk of dislocation is that you don't actually get the available range back in things like that close packed position, that external rotation.
Totally.
So they end up, as soon as they go a little bit into that, they've got such restriction that it pushes their humeral head forward and it pops it out. And they actually should be comfortable in that position, even if it's not a position they want force applied in.
It's that relationship of understanding that arthrokinematics is not constant. It actually varies based on the tension of the surrounding myofascial system. So it's like, just like you're highlighting there, of if you're going into that abduction external rotation position and you are getting anterior translation, well, what are the things associated with that? Sure, part of that is got to do with the coordination of musculature around the shoulder to balance out keeping the humeral head centered. But other part of it is actually just the tension of the soft tissue system as it's being wound up. And it's always an interesting one too, because typically when someone has a dislocation, like, well, don't do any flexibility. Now, don't be wrong, there's obviously things that you need to be cognizant of when someone has a dislocation to make sure that you're actually not irritating the actual shoulder joint itself, at the same time trying to actually open up other areas within the kinetic chain so they don't get secondary maladaptations.
People get so many restrictions, as you said, like through the scapula. They get so many restrictions through the anterior chest wall and the pec, and
even like
the
down
thoracic
through that chain.
Yeah, the thoracic spine. They lose a lot of because they automatically, especially if they've been placed in a sling, they end up really losing so much of that motion, and they get fearful of it. Obviously, it's even one of the tests is called the apprehension test. They get apprehensive about the movement that happens in their shoulder, but then that actually stops what happens a lot through the surrounding joints and surrounding tissue.
Yeah. So then, like, coming back to this question of like how do we develop high velocity movements in the upper limb, or how do we integrate that?
Yeah. So as I said, as long as you feel like they're applying, like they're creating enough force, and you're doing it in the ranges of motion that you think are useful for that person, and they've met some of that range of motion sort of criteria that we suggested before. I think the easiest way to do it is actually just take the movements that you've actually been using, whether they be rotational movements, whether they be pressing motions, pulling motions, and actually add some velocity to it.
Absolutely.
And the cueing that you use is one where you're asking people to actually try and move whatever implement they're using for resistance, whether it's their own body weight, whether it's an external implement, with some velocity, with some speed, and with some intent. Yeah. And it might mean that you need to change your parameters for your loading. So you might do more, less reps, but you're going to do them at high velocity.
Following basic training principles.
Yeah, but you're trying to actually expose them to a slightly different stimulus, which is to do it at a velocity. And I think that can be done really, really simply. You don't actually even need to change the exercise. If someone's doing a really basic, dumbbell lateral raise with 2 kilo weights, it doesn't really have to be heavy. If they've been doing it in a really controlled fashion, say if your tempo's, been something as simple as, 2 on the way up, no hold, no pause, and then 2 on the way down, or whatever it is, you can cut that to 1 or even half, and you're really extending up quickly or extending down quickly. That's going to allow them to actually understand that not only is that tendon going to tolerate that, but obviously their surrounding tissue as well. Yeah. And some people, I said, they're going to tolerate it. Some people may not tolerate it, but that's, your job is, as you said, run safe to fail experiments to work out where that is.
Yeah, and I think by even just going through that simple process of adding velocity to basic movements allows you to control the strain rate that they experience, because I think that's something that people often misunderstand too, that when you think about tendon, they have an ability to be able to store and experience forces of several magnitudes higher than body weight. But when you think about it as a per second rate, we're talking about 20, 30, 40 times your body weight. When you think about something like the Achilles tendon with sprinting, per second that is. So we need to make sure that as you add velocity, you need to make sure you're developing that whole sort of power spectrum, I think, as well, so that the tendon can actually tolerate building up velocity in a gradual way so that it can actually experience those strain rates and be able to adapt appropriately.
So with those ones, if you're thinking about it in that velocity spectrum that you just mentioned, they're probably at the moderate force, moderate velocity. You can start to go with some higher force, higher velocity stuff that goes into that sort of power spectrum. So that may be a number of the movements that we do are training movements that you would do for your upper limb. Whether that's something like Olympic lifting style movements,
which is actually really valuable to use some of those derivatives for doing
push press, push jerk, dumbbell snatching, or kettlebell
general snatching,
snatching with a barbell, those
snatch balances, all that type of stuff,
split jerks, all those kind of things where you're doing high velocity and high force to start getting some of those movements going. And the good thing with a lot of those movements as well is you can start to actually have them in that reception and catch position, have to create stability through that whole shoulder girdle and develop some of those things. So those can be really, really useful, I think, for developing that high force, high power, high force, high velocity tasks. And then one of the things that I think is becoming more popular and something that I've been using a little bit more, but I was kind of probably not as good with, is the introduction of, say, plyometric type motions for the upper limb. And some of them seem like they're difficult to implement, but they don't need to be.
Such as?
When you say plyometric, most people go, they're thinking lower limb, they're thinking of, bounding and stuff.
I think of gymnastics, actually.
Well, that's a good way of looking at it. I think the basics, the real basic ones that I tend to use often tend to be things like clap push-ups.
Yeah, of course.
Or push-ups on a bench where you're sort of exploding up and then catching down. Yep. Med ball throws,
yeah, of course,
is a big one, and med ball implementation with that, in different positions, whether it's double arm, single arm, depending on the size. Weighted balls, I know particularly with the throwing community in track and field, they use a lot of weighted throwing implements, and they'll use different weights to actually create some strength and force production there, which is going towards that it's reasonable force, but it's more being driven by the velocity end of that spectrum. And then, I think the last one is where the forces are not that high at all, but the velocities are really high. And these are like perturbation type movements. I think this has become a bit more popular where someone will be using either a band or they'll be having their hand in some sort of vulnerable position, and you're trying to create a perturbation about their hand or their forearm or their wrist and get them to be able to withstand that. And then obviously it's about those combinations of everything in between.
Absolutely.
You want to have the exposure to the different ranges and at high velocities and at high forces or very high velocities but not as high forces with unexpected perturbations. That's the ongoing game that you play. And clearly, as we mentioned, in an athletic population, you may need to go through every single stage of that. And in a sedentary population, you may only need to do one of those really more basic tasks, something like the high force, high velocity stuff. Like they might end up doing some dumbbell snatching. That might be, the maximum amount that you'll do. And it might even be heavy. It might be for a 70-year-old person who develops rotator cuff overload. You've taken them through all the force loading, through the range that they had available, then you've extended their range, and then they were doing, bind neck pressing, and they were doing ranges that were, more comfortable for them. They might do some body weight loading to really get that up. So like hangs or overhead handstand holds against a wall or something like that.
Yeah.
And then you're slowly like adding that velocity to it. For them, the last point of call might be something like, if you can do a dumbbell snatch, I'm not concerned that if you reach out for to open a door quickly, that you're going to, buckle over and say, oh, my tendon really caught me there.
Yeah, and so I think the thing that highlights too is for those more general population groups, the amount or the ratio of high force stuff you're going to do is typically going to stay a lot higher. But I think, and I think that's also something to be just cognizant of, to really emphasize it, of when you start going into the velocity end of the spectrum for tendon management, you really need to appreciate that when you start to add speed, the magnitude of forces can increase quite exponentially.
Yep.
And I think that's something that, because people are apprehensive to move into that velocity stuff, because it can actually aggravate symptoms, and obviously that's something that you want to mitigate. So be very mindful of the rate at which you do that, I think particularly for your older population groups, because their ability to tolerate those higher stresses is, I think,
you just have to really make sure that but it's the same as lower limb, you just want to really make sure that they are tolerating those higher forces, and then they're tolerating, higher force, moderate or moderate force, moderate velocity before you start adding very high velocity tasks.
Yeah, and I think that, going back to putting this all together, because I think a lot of people who will see upper limb tendinopathies will be in that general population group, is thinking about your timelines, and then again also thinking about what are the other modulators involved, because I think one of the issues that people will run into where they're not seeing the progression that they would expect is because you're not addressing those systemic factors that are modifying.
I think the timeline's a big one. Like, I know that I talk a lot with some of our younger staff when they start getting some of these patients in, even in an athletic population who develops a rotator cuff tendinopathy, is the timeline can be very slow, because typically the development of these, I think, is sometimes more related to those chain issues than they are to the specific tendon structure.
Yep.
Obviously the tendon has degraded at some level, and that's what's causing some of the presentation. But you end up in this position where you have to spend a long time unwinding, say, their thoracic spine, unwinding the connective tissue structures around their scapula.
Yeah.
As you said, that anterior chain of their pec, and, the abdominal wall.
Because again, it comes back to then, what's the main modulator here? Is it got to do with a poor load management through the actual tendon structure? That can be the thing that sets it off. Totally. Or is it a biomechanical deficit? And more often than not, it's probably a combination of the two. But again, this is really thinking about what are the key modulators associated with this person's presentation.
Yeah, I think that's one of the key things that I talk to them about. Don't expect that this is going to probably get better in 4 weeks.
Yes.
We see that sometimes in lower limb. If it's a really acute tendon irritation, you go through more of almost like an anti-inflammatory management, and acute management, it settles down. If you have someone who, has some sort of over stress to a tendon that's built up in the lower limb, you sort of go, well, we'll keep some loading on it. it will be, it'll warm up, it'll actually start to change its behavior.
Yeah.
In the upper limb, it tends to be much slower, and so you're typically looking at months, and then sometimes that's education, I think, on the part of the practitioner with the patient, and trying to work out what timelines are going to be reasonable, because obviously we all have expectations and goals that we're trying to achieve. But I think the experience that I've had is just that it's taken longer.
Yeah, absolutely.
Was there anything else that you wanted to cover there, Jack?
No, I think we've covered all the main areas.
Obviously, with these podcasts that we do, I think, it sounds like we're many times kind of giving out, what you should or shouldn't do. We hope that you sort of see it as, sparking some ideas. We know that we don't have all of the answers. So if you ever have questions about what we've put forward, or even disagreements, make sure you do reach out to us, whether it's on social media or via email or through the clinic, because we really do sort of enjoy being able to explore ideas that sometimes get discussed, sometimes they don't, and if we can sort of add to that, we would like to do so in this kind of forum. All right, thank you very much for joining us.